Hello, my name is Bart Van Der Worp, a neurologist in Utrecht in the Netherlands. And it's a pleasure to interview the chief investigator of this trial, Professor Julian Bösel. So Julian, congratulations with this, with completing this very unusual, very original, but I also think clinically very relevant trial. I think this must have been difficult, and I will come back to that later. So it's unfortunate that you didn't find any result on the primary outcome, but what I understood is that of the patients in the control group, not everyone had a tracheostomy. About 1/3 didn't have a tracheostomy. And I personally think that the main conclusion of this study is that by delaying the decision for tracheostomy, you can prevent tracheostomy in about 1/3 of the patients. Is this a conclusion that you can share?
Absolutely. Of course, it would be great to see another way of improving the cause and outcome of this very severely afflicted stroke group, critical care stroke group. And a neutral result is always a bit of a disappointment, but you hit the nail on the head. You can see it the other way around. You can say there's nothing wrong. There seems to be nothing wrong with waiting a little longer and starting weaning and trying to extubate these patients. You may be able to save them an invasive procedure in 20 to 30% of them. So, right, and our study also showed that dilational percutaneous tracheostomy seems to be a safe procedure regardless of timing. And we also employed a prediction score to assess the tracheostomy need, the SET score, and that worked pretty well in this trial, and that may be another way for clinicians to base their decisions on.
Okay, great. And so in other severe neurological conditions like severe head injury, brain injury, is there anything known on the optimal timing of tracheostomy?
No, there again are smaller studies, also a couple of randomized studies as opposed to a stroke, which only had one pilot study, that again suggest benefits like less ventilation-associated pneumonia or shorter ICU length of stay. But again, we don't have data that is really compelling with regard to long-term functional outcome that would suggest tracheostomy at a certain time point. So you may say the signal for benefits is a little bit stronger there, but we don't have definite data to do that. And the situation is much worse in many other neurocritical care conditions that you could look at.
Yeah, and you mentioned that you didn't find differences in secondary outcomes. Now, I don't know what the secondary outcomes were, but I can imagine that this is, for example, the length of stay at an ICU and the length of stay in hospital and the duration of ventilation. There were indeed no differences in these parameters.
Exactly, and it was a little surprising to us because our rationale was that the early tracheostomized patients may need less sedation and would be faster to wean off the ventilator and earlier to discharge to the rehabilitation center. But we did not see that in this larger randomized trial. And you may consider that possibly the early tracheostomy was not followed everywhere in uniform fashion by a rapid weaning or by aggressive de-escalation measures. But these are 25 dedicated neurocritical care centers in Germany and the US, and probably this reflects real life as good as it can be. So I think we have to face it that it's unlikely to speed up and improve all these secondary outcomes by this single measure of doing an earlier tracheostomy.
Okay. And did you also record patient satisfaction or something like quality of the hospital stay?
We did. I cannot talk about that too much because it belongs to another part of the study campaign. But we have collected data on patient and caregiver burden, things like waking up from coma, being able to make contact to the family, quality of life afterwards. That is another part of the study that we are looking into, and we may see interesting results and differences there.
Okay, looking forward. So, as already mentioned, this must have been a difficult trial to perform. Is that correct, or was it pretty easy?
No, it was certainly not pretty easy because to start with, the stroke subtypes that we dealt with here, severe acute ischemic stroke, severe intracerebral hemorrhage, severe subarachnoid hemorrhage, these are all so complex, and there are so many factors and confounders that have to be tackled by adherence to guideline-based treatment. So that's a challenge to start with. Another challenge is that this is a study done in patients that cannot consent themselves. So you have to convince a legal proxy and get consent from them. And that's another hurdle. But we managed to do that, but it was certainly not easy. Those are typical challenges in doing stroke studies in the neurocritical care setting.
Yeah, and you mentioned that you had 25 participating hospitals over a 4-year time period or so. So this is a recruitment of some 4 patients per year. Was this anticipated or was it disappointing?
It was fairly, we thought we could have been a little bit faster, yeah, but it was more or less anticipated. As I said, the courses of the patients are individually often not so easy to plan. And then there are, it's a very severe condition. So of course, to include a patient in such a trial would mean that there would be willingness for aggressive critical care treatment. And sometimes this willingness was not there, of course, which is fair enough. Yeah. And the other challenge and the other factor that probably slowed down recruitment a little bit was that we had to be quick. We had to randomize the patient before he was ventilated for 4 days. And that was quite a challenge because the whole process of recruitment and talking to a legal proxy or installing a legal proxy, for example, that's a little bit hard to do within a couple of days.
This all sounds great. I think it's a great achievement that you managed to complete this trial successfully. So congratulations again.
Thank you very much.